The next session on best of EASL, portal hypertension. May I please invite Dr. Nora Terold, Dr. Meena Bansal, Dr. Anil Arora, and Dr. Anoop Saraya to please chair this session. I'll take a quick minute. I request all the poster judges to please collect your judging forms from the following location. There is a poster help desk which is near the lobby area. I request you to collect the judging form from there. Also, there is a back hanger which is near the 24/7 restaurant. I request all the posters and the posters of distinction are the form to be collected from there. Thank you so much.
Okay. I think we'll have to. The next session is best of EASL, the latest research in EASL on portal hypertension. And to take us through the journey of what is new in EASL in 2025 in reference to portal hypertension, may I request Professor Matthias Mandhofer to come and present his data. And then we will have Dr. Akash Shukla, who will take us through the relevance in Indian scenario. Professor Mandhofer, please.
Thank you very much for the kind introduction. I'm the head of the Vienna Hepatic Hemodynamic Lab, so an institution that focuses on the study of portal hypertension. It's part of the Division of Gastroenterology and Hepatology in Vienna. Thank you very much for the invitation. When I started working at the university clinic, I had a fellow sharing the same office. His name was Anil, and he was from India, and he was wearing this t-shirt which read, "Come to India, 1 billion people can't be wrong." Actually, it's not really correct, right? 1.5 billion people would be the more correct answer. And with that, thank you very much for inviting me to your country and allowing me to share you the highlights of the EASL Congress 2025 on cirrhosis and its complications, in particular on portal hypertension and related events. And I would like to start with a study that is quite straightforward, focusing on portal hypertension. It was a benchmarking study on spleen stiffness in assessing the response to beta blocker therapy for secondary prophylaxis of acute red cell bleeding. And you will be very familiar with the institution where this research is coming from. It was the Institute of Liver and Biliary Sciences in Delhi, and the research was presented by Dr. Akhil. So to give you some background, HPVG is a minimally invasive and imperfect reference standard for assessing the severity of sinusoidal portal hypertension. Why imperfect? Well, because it's not broadly available and very resource intensive. And the gold standard or reference standard in general should be easily accessible. This is the main problem of HPVG measurements. But this can be overcome by non-invasive tests, and we've been studying this quite excessively. You can use liver stiffness measurement by vibration-controlled transient elastography, and you can use shear wave elastography for estimating the severity of portal hypertension. This is what we are doing in my lab, and which has been our research focus for quite a while. So we have patients with ACLD, we are measuring HPVG, and we also have the panel of non-invasive testing in these patients. And liver stiffness is very straightforward. However, you can not only assess liver stiffness, you can also measure the stiffness of the spleen. And there has been a technical innovation with the 100 Hertz probe for the FibroScan. Why? With the 50 Hertz probe, so the regular liver ultrasound probe, it was quite cumbersome to measure spleen stiffness with a technical failure rate of around 16%. And with the 100 Hertz probe, which is a spleen-dedicated probe on the FibroScan machine, the technical failures get much less, and it's pretty easily done. So spleen stiffness, it really has a role in the management of portal hypertension since Baveno 7. Why? With Baveno 7, it was introduced into the consensus statement, and this is my suggestion for Baveno 8, where I'm heading the panel on non-invasive testing. We will see more of spleen stiffness. On the one hand, we will see it to narrow down the gray zone after applying the Baveno 7 criteria. So if you're in the gray zone, which is around 50% of patients where you can't classify the CSPH status you add spleen stiffness, and then you can classify the patient. Or it's also integrated into models that use all the information from the NITs and give you an estimated probability of CSPH. So cross-sectionally, it has a role, but longitudinally, this is less clear. And this is actually where this study from India provides very important data. In this study, patients after an episode of erythroid bleeding were administered non-selective beta blocker treatments, and spleen stiffness and HVG were repeated to assess the hemodynamic response. And the primary objective was to see whether non-invasive tests can predict this minimally invasively measured hemodynamic response and replace HVG measurement to assess the response to non-selective beta blocker treatments. And what the authors observed was that the change in spleen stiffness measurement after 6 weeks had a high diagnostic accuracy for the HVG response, with a C statistic which reflects the discriminative ability of 0.85, which is a pretty good result. And even more, it was predictive of rebleeding. So it also predicted clinical outcomes, which is in the end what matters for the patients. And the authors speculate that this non-invasive response assessment would allow timely interventions in those who are identified as having a particularly high risk of rebleeding. So the issue with that is that this is a 6-week time frame, right? And a lot of things happen within 6 weeks that are not directly related to non-selective beta blocker therapy, but may impact portal hypertension. So I think based on this study, it is very hard to tell whether this was really the change that was monitored that was due to the beta blocker or just the evolution in natural history. At EASL, there was second research presented on the same topic, which used a different approach. Here, the beta blocker was not administered chronically. We just did an infusion of intravenous propranolol and assessed spleen stiffness and HVG directly after the infusion. And what you can see is that you have HVG responders and non-responders. You have decreases in the responders and no change in the non-responders. That's obvious. And then you see the dynamics in spleen stiffness. And the issue there is that if you just look at the response to intravenous propranolol, there's quite some heterogeneity in the responses. And although the decrease overall in the group was restricted to those who also had an HVG response, there's still quite some fluctuations in spleen stiffness, which in my opinion limits the diagnostic ability for something that is truly only due to the beta blocker and not just a reflection of the evolution of portal hypertension in the patient. So you can see our C statistic for response to intravenous propranolol as assessed by HVG was only 0.717. So I think to monitor the evolution of portal hypertension, spleen stiffness could be really informative, but the response to medical therapy itself is very small, and this will be quite hard to detect by spleen stiffness, although 0.717 is not nothing. And with that, I would like to change the topic and move to albumin treatment in the course of acute kidney injury. And this is research that is not coming from India, but from Germany, so European research on the response criteria to albumin administration. So let's go a step back. Let's see what the EASL CPG tells you about use of albumin in acute kidney injury. We have this wonderful EASL guidelines app, which is free to everyone who registered, so you don't have to be a paying EASL member to make use of this app. I have it on my smartphone. This is just a screenshot. And I looked up AKI and albumin. And this was the result. This is actually the flowchart from the EASL CPG on decompensated cirrhosis from 2018. Very small, but you can make it bigger. And here you can see the role of albumin. If you have a patient that has AKI above 1A, so at least 1B, this is fulfilling the AKI criteria and having a serum creatinine above 1.5, we administered albumin, and then based on the response to albumin, we could tell whether the patient has HRS AKI. And in those that are meeting the HRS-AKI criteria, which you could only assess after the administration of albumin for 48 hours, you were then initiating the vasopressor. However, there's been the ICE ATQI criteria that have been recently proposed and published in JHEP. And here, this management of your patients with AKI has changed because the administration of albumin was restricted to those with hypovolemia, and the time frame for assessing the response to plasma expansion was only 24 hours. And also the creatinine threshold of 1.5 for having the AQ1B and mandating albumin treatment was removed. So, and this was basically the focus of this study. It's a real-life study in 127 patients where volume expansion for 48 hours was performed. And then the authors initially aimed at assessing which criteria define a good response to albumin because they're prognostically relevant. And basically here they confirmed that this definition 3, so the decrease for at least one AKI stage, which was proposed in EASL back in 2018, was the most suitable definition. But this is not really the most important point. The most important point of this research is that if you have a patient that is administered albumin, after 24 hours, you have some response, but many patients who do not respond after 24 hours will respond after 48 hours. So with increasing time and really waiting for these 48 hours as initially recommended back in 2018, you can spare some use of vasoconstrictors. And the authors also came up with an earlier definition. So if your patient at 24 hours is already increasing with the serum creatinine above a certain threshold, you could already predict that he won't increase, that he won't decrease after 48 hours. So this could be an option to early use vasoconstrictors in these patients. So the full manuscript is already published in JHEP, and you can find it online via PubMed. Then the next study I would like to show you was a phase 3 trial. It was a phase 3 trial on long-term albumin therapy in cirrhotic patients with acute decompensation due to ascites. It was the Preciosa trial that was long been awaited. You're all aware there was a positive open label study coming from Italy, published a while ago on long-term albumin treatment. So this phase 3 trial was very eagerly awaited because it was expected that it could confirm the results. So let's take a step back and look at the treatment options that we have for ascites. Well, we are mostly restricted to treatments that act down a pathophysiological cascade. So we perform paracentesis, which is basically a symptomatic treatment. We use diuretics, but the question is, can we do something upstream? And upstream, you can either target systemic inflammation or the circulatory dysfunction which occurs in these patients. This can be done by albumin. And upstream, you could also use tips to lower portal hypertension to basically address the cause of ascites. And long-term albumin would be one of these upstream options. And this phase 3 trial was also open label. And the regimen that was used in the intervention arm was albuterol 20%. At a dose of 1 gram per kilogram body weight, so quite a high dose, every 2 weeks, or 10 days actually, for up to 12 months. And the primary endpoint was transplant-free survival. And if you have a phase 3 trial, you always have to look at the assumptions that were used for the sample size calculations. And here, a hazard ratio of 0.6 was used with a power of 80%. So I would say this would be a very, very substantial therapeutic effect that was suspected. Based on these assumptions, the primary outcome was negative. The hazard ratio that was seen for transplant-free survival at 1 year was 0.8. Obviously, you can do exploratory analysis at other time points. Some of them were positive. However, you have to consider that this is multiple testing that has not been accounted for. So the primary outcome of this trial is negative, although there were some beneficial effects seen on secondary endpoints. So what is also important is safety. There were some safety concerns related to albumin. However, even used at this quite high dose with a dosing interval of 10 days, it was very safe. So the side effect profile was actually numerically more favorable in the albumin arm than in the standard of care arm. So I think this is reassuring in regard to the safety if albumin is used at a high dose, but still at quite a long interval. So, well, negative in regard to the primary outcome. What can we do? Well, you know, we can still target portal hypertension. So even if long-term albumin is not a well-established treatment at this point, we can still move even further upstream and direct and target the cause of ascites. And we can use TIPS, and we should use TIPS early already for recurrent ascites, as shown by this French study by Christophe Borot. Actually, the median number of paracenteses in the previous 3 months in these patients were 4. And what we could see is that in the TIPS group, the number of paracenteses was lower, that's obvious, but this patient didn't have more overt hepatic encephalopathy, and hospitalization was decreased, and survival was much better at 1 year. So if you move back to evidence-based medicine, in my opinion, using TIPS for recurrent ascites already quite early in the natural history, where it has a better safety profile, is a very straightforward approach. And if you take the number needed to treat from the Borot study, this is really impressive. This would be something that I would really consider as a disease-modifying effect, because the number needed to treat was as low as 2.5, which is very rarely seen for interventions in the medical field. And then I would come back to a study from India, and this study is not only from India, it's even from Chandigarh. It has been, it had Nipun Verma as the primary author, and it focused on gut colonization guided versus routine empiric antimicrobial therapy to manage infections in patients with cirrhosis, and it was a pragmatic randomized trial. So what about multi-drug resistant organisms? Well, the colonization with the organisms, it predicts infections with multi-drug resistant germs, and usually the infections that occur in these patients who have rectal colonization, they are by the same germ as the one that has been detected in the rectal swab. And this is basically the rationale that has been used in this Indian study, which is a high burden setting for multi-drug resistant infections. And they used a gene expert for carbapenemase resistant genes, and also microbial culture to detect this carbapenem resistance in the rectal swab, and then administer a specific antimicrobial treatment strategy in these patients, which targets this resistance, and this was primarily ceftazidime and avibactam and aztreonam. So it was a randomized trial. In one trial, this gene expert and culture-based detection strategy was used, and the rectal swab then guided the antimicrobial treatment. In this intervention group of 51 patients, 43 actually were carbapenemase positive. This is something that is super surprising for someone coming from the Western Hemisphere, but I will allude to that later. And 40 patients received the specific antimicrobial treatment. And the resolution of infection was higher in this intervention group, which translated into profoundly improved outcomes with a hazard ratio of 0.53 and a number needed to treat of 4. So this is the first randomized trial that actually shows that guiding your antimicrobial strategy by this MDR detection in the rectal swab improves outcome in patients with cirrhosis. The issue is, which I mentioned earlier, these high rates of carbapenemase is something that is surprising for us, and this may also reduce the generalizability of this study to other settings. Here you can see data from Europe in patients with cirrhosis. You can see that MDR in general is not that common, and carbapenem resistance is very rare, and extensive drug resistance in Europe is also quite uncommon. So possibly we are dealing with less antimicrobial resistance, which would actually increase the number needed to treat quite significantly, because what we are aiming to detect and improve is simply much less common. And with that, I will take the last couple of minutes to wrap up. So India is submitting its research highlights to the EASL Congress, and we are very happy about this. As a result, there were many prominent presentations by Indian authors in the field of portal hypertension. I've been mentioning 4 presentations. 2 of them were coming from India. I've been speaking about spleen stiffness measurement at 100 Hertz. On a cross-sectional level, this is an excellent test for clinically significant portal hypertension, either in the gray zone of the liver stiffness and platelet count-based Baveno 7 criteria, or integrated into the NICER model, which compromises liver stiffness, spleen stiffness, platelet count, but also considers BMI. However, the longitudinal changes in HVBG, they are quite difficult to monitor with non-invasive tests, and I'm not sure whether it can be used to detect these minor changes in HVBG that result from beta blocker treatment on an individual patient level. However, we also have to keep in mind that even HVBG has problems with test-retest reliability, so we don't really have a very good gold standard for the evolution of portal hypertension. However, I think that spleen stiffness may have a role as a surrogate of portal hypertension in clinical trial settings, where you're interested whether your medication itself has implications for portal hypertension and is effective on a population level. Then I think I've been showing you that it is worth to stay calm and stick to the 48 hours of albumin for AK1B, and wait with the vasopressors a little bit, unless, and I'm also a physician that is certified in critical care medicine, you obviously have a hypotensive patient, and it's a very good thing to treat hypotension with vasopressors, so possibly you should start early in these patients. Then I've alluded to that the benefit of long-term albumin therapy is still unclear, potentially some disease-modifying effect, but the primary outcome was negative in this phase 3 trial. We have possibly more effective treatment options, and this is TIPS as a disease-modifying treatment, not only in recurrent, so very advanced ascites with poor hepatic function, but possibly better in earlier, not only in refractory, so very advanced patients with poor hepatic function, but possibly more in the recurrent patients with better hepatic function, where TIPS has a very favorable safety profile. Then finally, the colonization with multi-drug resistant organisms is clinically significant, and we've been seeing very interesting results from India on how this colonization testing can be used to guide your antimicrobial treatment. Possibly this is something like a crystal ball for Europeans, because it's mostly a look into the future, because antimicrobial resistance is also an increasing problem in our area. But at this point, the generalizability of the findings to our region is not really clear. And thank you very much for the invitation, and looking forward to discussion.
Crisp presentation and giving your views on these studies. Now I invite Dr. Akash Shukla to moderate the panel discussion and on these studies and implication of these researches on clinical practice in India. Our panelists are Dr. Arun M., Dr. Ankur Jindal, Sandeep Satsangi, Dr. Sagnik Viswas, Dr. Vijay Alexander, and Dr. Babulal Meena.
Good afternoon, everybody. Uh, Thanks, Matthias, for the lovely slides and the detailed discussion. Uh, and welcome all the panelists for this interesting discussion that we are going to have. We'll start with the last abstract first. That is the gut colonization guided versus routine empirical antimicrobial therapy to manage infections in patients with cirrhosis, a pragmatic randomized control trial. A topic which was extremely interesting, and I think for all of us who are practicing in high-end ICUs, this is a definite problem that we are facing. So, Dr. Arun, we'll start with you. So the timelines which they have given in the abstract, where they have talked of tests which are done at baseline. Carba test will give you the result the same day. The cultures will give you the result on day 3 or day 4. How do you define on the first day what antibiotics you are going to give to this patient based on this in real life as compared to trial setting? Where in trial they have said on the baseline itself they do a carba test and then they send. While in real life, when the patient comes, when you're seeing the patient first, you immediately start, you prescribe. So how do you adjust for this time frame difference between the two?
So thank you very much for your kind invite, sir. And in cirrhotic background, as we have come across, more than 40 to 45% the critical ICU setting will be coming across infections. So very common scenario. And once we are going to tackle this infection, we are coming across with healthcare associated, hospital acquired or community acquired. What are the infections we are going to tackle? That's thing. Apart from that, see, in real life scenario as well as in trial. So what is the basic things? If you're going to, in gut colonization, that shows a significant area of improvement. So based upon that, the antimicrobial therapy, if you're going to guide. So what is the basic target? First, we need to collect the stool samples. If you're going to take a rectal swab as well as samples, within 24 hours to 48 hours, we need to collect, we need to process the data, and along with the computerization. So we need a proper expertise guidelines. That's very, very important. And apart from that, infection control, whether the patient we have, whether any ID team is there ready to tackle this kind of infections, that is very important. And apart from, we need to have a proper follow-up. So in order to identify the colonization, we don't have much of time. So we need to have a proper, so initial setup of diagnosis followed by every 3 months, we need to have a proper sample collection. That is how we need to have follow. But what is happening in real life setting? We are not, it's most of the time the sample collection will be taking around 25 to 48 hours. And sometimes the patient will be going around, the processing will be going almost around 72 hours of duration. And ideally, most of the time the patient will be having outpatient setting is very, very difficult to have a proper data assessment and all those things to get followed. And infectious disease consultation will be very difficult. And choosing the antibiotics. Why? See, carbapenem's resistance will be very common. So if you're going to choose a gut colonization data,
I request Arun, can we be brief and to the point? Otherwise, we'll not be able to finish.
Yes. Yeah. So this is how. So gut colonization derived the trial as well as the background is very important to tackle this kind of presentation.
Yeah. So the challenge here is, if you look at the sepsis bundle, all the critical care guidelines, they say if a patient is coming with a sick in a sick condition, you would want to start your antibiotics within the first 1 hour, and that is an important determinant of the outcomes of the patient. And here you are saying you do 2 tests, one of which will give you result in around 4 to 6 hours, and the other one will give you a result after 72 hours. And then you decide your antibiotics, empirical antibiotics based on that. So I think in practical implications of this, I would be skeptical based on this, unless we have more details coming forward about this. The second is, the authors have said that they included only patients with bacterial sepsis, bacterial infections. So my question to Dr. Ankur is, when a patient presents to you with an infection, let's say fever, at the first go, how easy or difficult it is for you to say whether it is a bacterial infection, fungal infection, or a viral infection, and you have to start the antibiotics immediately, so you will take a rectal swab and then decide. Because it could be a viral pneumonia, it could be a respiratory syncytial virus, which we are seeing so commonly these days. And you'll be unnecessarily giving this person, let's say if he's a colonizer with an MDRO, you will be giving this person antibiotics which are for a MDR infection, while the patient is actually having a viral pneumonia, which clinically sometimes may be very difficult. So what are your thoughts on this?
Yeah, very important question. It is in clinical practice, it is very difficult to differentiate sometimes the type of infection the patient is having, whether it is bacterial, fungal, or viral. The fungal infections, as you see, is more common in patients who are on prolonged ICU and long-standing antibiotic use, patients on ICU mechanical ventilator. So this is a completely different setting. So difference is mainly in the bacterial and the viral infections. So as you said earlier, every hour delay in the appropriate antibiotic use worsen the outcomes in a patient with cirrhosis. So we need to start the empirical antibiotics, especially in the sick patients, like the patients who are having ACLF at presentation with suspected or proven infection. There is no way we can confirm at the time of presentation whether it is bacterial or viral. We have to start the empirical antibiotic therapy. So the main thing is the patient in cirrhosis is many patients have the spontaneous infections, and there is a worsening of the clinical status with the infection, like the patient developing AKI or patient HE, which is a marker of infection in these patients. The biomarkers are very unreliable, like CRP, procalcitonin.
Yeah, but Ankur, all that happens later on.
Yeah.
We are talking of starting antibiotics at baseline,
Yeah.
upfront. And
So-
that is where I see a huge challenge when you talk of
So in a sick cirrhotic who is infected, we need to start the empirical antibiotics, mainly broad spectrum antibiotic. Sicker the patient in the ICU, we need the carbapenem. We need to use the carbapenem plus the MRSA cover. We should give empirically, and then deescalate the antibiotic depending on the cultures and the other.
but in fact, here is a inherent, contradiction, because on one hand we talk of antibiotic stewardship, because we are choosing resistant organisms. And on the other hand, by using a swab and choosing Zevicefta aztreonam as your treatment of choice empirically based on a rectal swab, where you don't even know whether it is a bacterial infection or a viral infection. Don't you think there's a paradox in this? I would want to, anybody else, Professor Arora?
Yeah, I fully agree with you. You see, I think the two important spokes which are missing in the cogwheel are how are we sure that the rectal swab organisms have a direct relationship with what you are seeing on clinical grounds? Is there a baseline data?
That's the next question I'm coming to.
That is something which is important. Unless you do that, if you are missing that important spoke in the cogwheel, you're not going to progress. Secondly, majority of the infection maybe in patients with cirrhosis who get decompensated may not be related to what is happening in the rectum. So that premise I am not able to understand.
Right. So this is exactly was my third point. Dr. Sandeep, you can probably take it. So in such patients, 72 hours later, you get a rectal swab culture which shows a MDRO. And this patient has a chest infection, and you get a sputum which shows a sensitive organism. Let's say it's a pneumococcus which is sensitive to ceftriaxone. Which one would you believe and which one would you choose to treat?
Sir, I would completely agree with your point. I think I was actually discussing with Nipun just before this talk. Just because you're having a CRE positive bug in the rectum, what is the concordance that is the thing which is leading to the infection, let it be in the lung or in the SBP? So if we have a sensitive bug in the lung, I think you should go with that rather than just going with your broad spectrum. Otherwise, there'll be an overzealous use of these antibiotics and you'll have a lot of resistance coming up. So I think we need more data from Indian setting about the concordance between having CRE positive in the rectum and maybe a culture in the SBP or in the pneumonia. Only then maybe we can frame this.
Yeah, thank you very much. So what we need to demonstrate, and this is the future research, which I think we would be interested in, is if you can demonstrate in a patient who has been following up with you, routinely in outpatient, where you have taken a rectal swab, and when this patient comes to you with a infection, if you can demonstrate the same bacteria in the blood and demonstrate that there is actually bacteremia happening with the same strain, same genotype in the blood, then I would be convinced that probably yes, this rectal colonization can translate into infections which are from the same bacteria, which are drug resistant, and therefore merit a higher level of antibiotics. So, Dr. Sagnik, you would want to take this up. How do you think we can plan these studies and what should be done?
So to just address this question, rectal swab as a source of bacteremia, it is a low risk procedure. It has been shown in studies to not be associated with significantly high rates, but it is a tangible risk in a patient who is acutely ill, particularly cirrhotic. And another thing I would like to raise in this point is that any acute decompensation is known to be associated with elevated portal pressures. Doing a blind rectal swab, what about the risk of injury to rectal varices? I'm sure that will be addressed when the full text comes out. Regarding these studies, so the points which have been raised till now are definitely valid, and they need to be validated that whether just the presence of an MDRO translates to an organism in the bloodstream, because we are treating with very high-end antibiotics which will treat everything. It doesn't matter if it is MDRO from the gut which is coming or something else in the blood, but carries a significant risk of antibiotic resistance, misuse of antibiotics, which I feel has to be addressed.
Thank you, Sagnik. And Dr. Vijay, coming to the last part, in this group, actually they have excluded patients who are immunosuppressed or who are on drugs which are immunosuppressed or immunosuppressants, or patients who are immunocompromised. So, do you think it is appropriate to exclude these patients, or rather you would include these patients, because those who are on immunosuppressants are actually more likely to have bacteremia from the colonizers rather than the other group. So, your thoughts on this?
Yeah, so just from the abstract, I'm quite unclear on what the threshold for defining the patient to be immunocompromised was, so as to exclude from the trial per se. But having said that, maybe an exclusion of a patient with a high degree of immunosuppression would probably maintain a certain level of homogeneity to the patients included. Having said that, aren't we all dealing with these patients who are generally immunocompromised? So that's both sides of the argument there.
So, yeah, so thank you so much for those thoughts. I think this is a very interesting topic. It is a topic which has been discussed in ICUs for quite some time. I think we have all been discussing this on rounds. So, this gives us some insights, but I think it throws more questions than answers. What we need to know is whether this was just a surrogacy and whether it was just a chance finding, or is there really a true cause and effect relationship and it gives you a new target? I think that we don't know yet, and that definitely cannot be answered by this study. So I think all of us, we should plan studies together, probably a multicentric study where we can pool this data prospectively and not only look at just the outcomes, but the exact pathophysiological basis and the translational process, whether this actually translates into bacteremia by the same organism and that reaches the other target organs and causes infections there. So I think those are the open-ended questions which we need to address. Matthias, any? Yeah.
Yeah. Do we have a data that across the spectrum of patients with liver disease, child A, B, C, are these commensals or are these the causative agents? And secondly, most of them will ultimately get transmitted into the blood, but does the rectum cause increased permeability, or it may be a small bowel which is more relevant?
Yes,
all
sir.
those
So,
questions are important.
yeah, absolutely. I agree with you completely. So we don't have that data, and we don't even know about the small bowel colonizers. Yeah, Matthias, you want to say something?
Yeah, I think one issue that we also have to think about is, the causal relationship and the causal interference, which is always very hard to answer by a pragmatic trial, because, in the end, 40 of 51 patients, if I'm correct, were receiving an extended antibiotic therapy in the intervention trial, and possibly the test itself, which was positive in the majority of patients, was not important at all. It was just a broader antibiotic treatment that in a way could also have been empirical, that led to the positive results. So I think this is something that is important to keep in mind, to look into the causation, but this is also something that you alluded to.
Absolutely, I completely agree. In fact, just to add to it, we don't even know the validity of the Carba test or the rectal swab in Indian setting and in countries which have got high prevalence of MDRO infections. So I think Yeah, Ankur, you want to make some point?
One thing is not clear in this abstract is that it is should in the empirical antibiotic therapy. If a sick cirrhotic patient comes with suspected infection, we should start the antibiotic irrespective of the rectal swab report. So we should we wait for the rectal swab report and the carbapenem?
Yeah, that was my first point. Yeah, so agreed. Point well taken. So let's move on to the second abstract, which was benchmarking splenic stiffness in assessing response to beta blockers for secondary prophylaxis of acute variceal bleed. So we'll start with Dr. Babu. This is from your institute. You have a fantastic carvedilol protocol which you give as a handout to every patient of yours from your institute. I've seen that protocol. So would you want to educate everybody, because that is what was the basis, I assume, for the dosage of carvedilol in this study, or was it any different?
Yeah, the protocol, basically the study protocol includes measurement of HEPG at starting and 6 weeks after starting of the beta blocker therapy.
No, the dose of carvedilol, how you have given.
Yeah, so dose of carvedilol, it was initially started at 6.125 milligram twice in a day, and it was titrated up to maximum 12.5 milligram twice in a day, and at the interval of 1 week after starting of the treatment. And HEPG was monitored at the start and at the end of the treatment, and splenic stiffness was monitored at 0, 3, and 6
Yeah,
weeks of the beta blocker.
that was given. So coming to the, anybody of the panelists can take this question. How often are you actually comfortable starting your patients on 6.25 milligrams twice a day? How many of your patients tolerate that dose? So maybe Sagnik, you can take this.
So with higher doses, we have noted that patients do come back with complaints mainly related to dizziness or generalized fatigue, weakness. So we usually do not reach very high doses.
Yeah, so we have been finding it difficult in our patients. I know there are a lot of centers who start off with that dose, and you can go up to 12.5 milligrams twice a day, but it's very rare for at least in my practice, for me to reach that level. I think it's a very rare patient. Matthias, is it any different for you all?
So we're starting with a daily dose of 6.25 for 1 week, and then if the tolerability is good, patient measures blood pressure and the patient waits for symptoms, then we increase to 12.5, and to 25 as a daily dose, we're only going in those that have arterial hypertension. And in my opinion, the tolerability of carvedilol is as good from a clinical perspective as propranolol.
Okay. So here, the rebleed time was not defined up to this thing, how long. I think at one place they have mentioned 90 days in comparison, but what was done for, again, this Ankur, maybe you can take because you are part of the study. So what was the timing, that time frame that you took, and what was the strategy for the non-responders or the intolerant? And were these patients subjected to repeated endotherapies? And was preemptive tips offered to any of the patients? Because these questions were not there in the abstract, which came to my mind as I was reading it.
Yeah, rebleeding was defined up to 42 days. So early rebleed was defined up to 42 days. After that, it was the late rebleed. And the strategies for the non-selective, non-beta NSPB non-responders were the EVL. EVL plus non-selective beta blocker was used in most of the patients. In those patients who are not tolerating the non-selective beta blocker, if they are using the carvedilol, then the propranolol was used in the lower doses along with the along with the EVL sessions for secondary prophylaxis. And the impact of endotherapy. So every patient got serial endotherapy every 3 weekly till the varices eradication as secondary prophylaxis, and the preemptive tips was not offered to most of the patients.
So because it is quite surprising, if we are doing it so much, your rebleed rate was still 16 to 17%, which is not what you would usually see in your clinical practice. So any reasons why the rebleed rate within 42 weeks was so high, and any reason for denying these patients preemptive tips when they fulfilled the criteria?
So I think I'm not. In general, we see in our practice most of the rebleeds we see in our GI bleed unit are most those patients who are having not the appropriate dose of the beta blocker. So they were on the lesser dose of the beta blocker. They are not hiking up the dose of the carvedilol up to the maximum tolerated dose. And moreover, the sessions of EVL which are required every 2 to 3 weekly, some of them may have missed the EVL sessions. and delayed death.
Because those will be very important determinants, because we are saying that at 3 weeks, when we look at the splenic stiffness, that is predicting the HUPG response at 6 weeks. So, but if we are not achieving our target therapeutic dose at 3 weeks, if we are not achieving our endoscopic eradication at 3 weeks, then is it really appropriate to do a multivariate analysis at 3 weeks when you have inadequate data?
Yeah.
Thank you. So, coming to Dr. Arun, are there any problems with reproducibility of?
No, I just had a clarifying question. Was alcohol consumption factored in at all? In other words, those who stopped drinking had a reduction in spleen stiffness and were responders?
Yeah, so at least 46% of the patients in this study were alcohol-related liver disease. And we don't know the data on how many of them abstained and how many of them continue to take.
That's a major confounder here.
That's a big confounder. Yeah,
Not only alcohol, all treatable factors will lead to reduction in the portal pressure, be it hepatitis B, C, alcohol, MASH, control of diabetes, that will have compounding effect on this.
Yeah, that's a confounder. But so in that way, I think it is appropriate, because irrespective of that, the splenic stiffness would reflect it. And in that case, it is less likely to bleed as well. So yes, that is one of the factors, but that would be accounted for when you measure the splenic stiffness or the HVPG, irrespective of what is causing. But how much is the delta between 3 weeks and 6 weeks? We don't know in terms of these etiological factors.
16% means every 6th patient will rebleed, which is not true in general practice.
Yeah.
In real-time practice, every 6th patient is the bleed. You will never be having good practice at all.
I agree. So, any practical problems when you talk of splenic stiffness measurement, reproducibility? Are there data differences between cirrhosis and non-cirrhotic portal hypertensions?
Yes, sir. So regarding splenic stiffness measurement in the background of cirrhosis is mainly because of sinusoidal changes. But in EHP and in non-cirrhotic portal hypertension, it might be because of pre-sinusoidal or post-sinusoidal. It might be NCPF or so many other things. So usually more of homogeneous changes will be coming across in case of cirrhotic focus, and more of heterogeneous changes will be coming across in case of, so inter-observed variability will be very common scenario when you're going to come across the non-cirrhotic portal hypertension and other things. So in order to target that, the stiffness, we need to measure that 20% reduction within 3 months of initiation of therapy. And here we need to have a more aggressive trial. Within 4 to 8 weeks, we need to bring the splenic stiffness almost around 15% when you're going to initiate the therapy.
Thank you very much. Yeah. So, does this answer in yes or no? Does this change your practice, Dr. Sandeep?
Sir, for now, I think no. Presently, I think you made a point that most of the centers would start carvedilol at 3.125 mg BD and slowly escalate it to 6.25 BD. And that is dependent on the heart rate, 25% reduction, or get it to around 55-60. I think this is an add-on we can do. At 3 weeks, if you don't have a reduction of splenic stiffness, maybe those subset can go for a preemptive tips, is one of the way I can think that it can be used in a clinical practice.
Okay, great, thank you. So, I'll request everybody to be brief, and I'll try to be very brief myself. Coming to the effect of albumin treatment on patients with cirrhosis and acute kidney injury, I think this was a wonderful study which has actually asked us to be more relaxed in terms of starting vasoconstrictors. So, volume expansion in real life versus clinical trials. So, do you use albumin alone, or you use Dr. Babulal, or you use something else? Because the intensivists say, the critical care guidelines say, you can use anything that is a crystalloid.
So in real life, actually, along with albumin, we also use crystalloids because of the availability of albumin and because of resource limited issues. Number one. Number two, if the patient is in shock, obviously we have to replenish with crystalloid also, and 20% or 25% albumin may cause more adverse effect as compared to the possible benefits. So in real life we use other type of solution also, and but obviously in trials we use 20 or 25% albumin.
Okay. Dr. Vijay, coming to you, when you take your rounds, Matthias beautifully told us that in some patients you can easily wait for 24 hours more, wait for 48 hours, and then you can decide whether you can start vasoconstrictors. So in your routine rounds, do you come across patients where when you see them, objectively, they don't fulfill the response criteria, but looking at them, you know, oh, this patient looks to be much better than what I saw him yesterday. And let's hold on for the 30% of vasoconstrictors.
Yeah, that's quite often a scenario, sir. In terms of determining response criteria definition for a trial, you have to be objective, and these criteria do work very well that way. But at the bedside, what is the next best thing to do in terms of do I hold off on fluids? Do I give a shot of loop diuretic? Do I start HD? All of that would be a clinical bedside judgment.
Thank you. Dr. Arun, what could be the reason for this delayed response beyond 24 hours?
Mainly in the background of cirrhosis, there will be severe circulatory dysfunction. Apart from that, the patient will be having multiple inflammatory cascades will be predisposing, and also cardiovascular dysfunction. And apart from the poor albumin binding capacity, if you are coming across the target site, the poor albumin binding capacity will be coming down. So all these things will be preponderant. So also the rapid responders and non-responders are a very common scenario when you're going to address this scenario, sir.
Thank you. So, Dr. Ankur, does this change your practice, or your practice was always 48 hours?
Yeah, it is 48 hours, but only in subset of patients who are like AKI in ACLF patients, because the rapidity of worsening of AKI and the organ failures is very rapid, and we need to initiate the vasoconstrictor early in the lower doses, because if we wait for 48 hours, then it will be too long a delay. In cirrhotic, it is okay, 48 hours.
So, just as an add-on, your center is also published on early CRRT for patients with AKI. So, where would you place CRRT? Because on the one hand, we are talking of delaying the addition of vasoconstrictors. On the other hand, we are saying early initiation of CRRT. So,
after the initiation of vasoconstrictor, if there is no response, even after vasoconstrictor of 48 hours, then we may consider the early CRRT.
Okay. So, last, I think we have run out of time. So, for the last abstract, long-term human albumin therapy, it did not achieve the primary endpoints. That was improvement in the survival, transplant-free survival or mortality, but it did show improvement in the incidence of acute kidney injury and ascites. So, the inclusion criteria, which Matthias also alluded to, was existing or prior ascites. So, in patients who have prior ascites, would you really even think of giving long-term albumin therapy, Dr. Sagnik?
Sir, probably not if the ascites has resolved. I think this brings into point that this was a heterogeneous inclusion criteria. Resolution of ascites can be, again, drug-related due to diuretics. It could be recompensation. The onset of ascites, acute versus non-acute, there was a recent publication in JOH regarding that. They all have different outcomes. And I think that is the heterogeneity which came in here and affected the final results.
So, it's very interesting because we still don't know which is the right cohort of patients who are going to benefit from long-term therapy. So, we still have a big denominator. If we can narrow down this denominator to and identify the predictors that this cohort of patients with these characters is going to respond to long-term albumin therapy, probably we would be, that would be probably the question to answer. The other thing, which was albumin every 10 days versus albumin every week in the answer trial. How does that really impact? Anybody can take this question, and Matthias, your thoughts. Why 10 days and why not 7 days?
So yeah, I mean, there's several trials over the years that have been conducted. It's not only the ANSWER trial, but there was also a trial in very advanced patients from Barcelona before that was smaller, and also several others, and the albumin schedule, it varied. So if you look at the normalization of albumin levels, so those who normalize the albumin have usually a better outcome. So obviously those matters, but I think there's two questions that are yet unanswered. And the one question is which population of patients benefits? And the second question is what is the right dosing regimen, right? And these are two questions that are very difficult to answer if you don't have a general proof of efficacy. That is usually done in phase 3. And these are questions that should be answered before the phase 3. So now the phase 3 was negative, and we'll see where that goes. And this limits the answering to these questions either to investigate, initiate study, or further attempts, and we'll see whether these happen.
Yeah, thank you, Matthias, because if you look at the subgroup analysis in the previous trials, it had shown if you touch albumin levels of more than 4 grams, that is what is going to be associated with better outcomes. And in real life, it is very difficult to achieve albumin levels of 4 grams for majority of our patients. I think for want of time, I will end here, and I will request the chairpersons to give their final comments before we wind up.
I think even long-term albumin, yeah, throws up more question than the answer. Regarding the target level to be achieved, there is no consensus. The type of the albumin which needs to be given has no consensus. Now, a negative trial further puts a blot on the utility of this, because domiciliary IV albumin has its own flip side. There are patients who will have reaction which may not be managed at home. So unless, as you very rightly said, we have a specific denominator of which subgroup is likely to benefit amongst the host of the people with decompensated cirrhosis, I think routine recommendation is not followed by everybody.
I think Nipun is here. We would want to hear from him. He is the one who did the trial, so he can give us more insights about the doubts that we have.
Hello. Yeah. Thank you very much, Dr. Matthias and Dr. Shukla. I really enjoyed the way we discussed this. And this was the whole debate we started in our department. We took 7 days to debate and coming to a conclusion how we are going to do this. So the first question, you said that timelines. Let me clarify, none of the patients were stopped empirical antimicrobials at the outset. Patients were already on empiric antimicrobials and they were modified based on the rectal swab results. So patients were already, so the to exact figures, 70% were on ceftriaxone and around 30% of patients were on piperacillin plus tazobactam as an empiric therapy to start with in both the groups. So the antimicrobials, so let's say we have a patients with acute decompensation with SBP.
So you start the antibiotics and then you modify based on the
rectal swab
and then at 72 hours based on the culture.
Yes.
Okay,
so
got it. Point well taken.
So the point here is the cultures, the yield of cultures is 25 to 30% in our setup. Therefore, there is an unmet need to find appropriate antimicrobials at the outset to improve the patient's outcome. And we all know adequate antimicrobials. PREDICT study has shown, Carvelas has shown each hour delay is going to lead to 1.8 times higher mortality. So the agenda was this, how we can early diagnose and target our therapeutics for infections. So we are not treating colonization here. We are treating patients with infections. As per the EASL criteria we chose, we excluded all patients who were suspected infections but not a clear cut focus. So focus was very clear in all these patients, either SBP, pulmonary or urinary tract. Urinary tract were very low. So these were predominantly pulmonary infection, 30%, about 60% were, SBP. Regarding the second question was, what is the concordance in Indian setup? In Indian setup, our previous study, 120 patients and then 200 plus patients from ILBS, both have shown concordance of rectal swab cultures with the infective organisms to the tune of 80%. Now, if you go to the European cohort from Barcelona, Frankfurt, there is a study published in Prado, Prado is the first author, in Journal of Hepatology. They showed the concordance up to 90% in the Frankfurt cohort, and in the Barcelona cohort, it was 82%. So the concordance is there. This concordance was also seen in non-cirrhotic patients as well. So there is a strong premise not only in hepatology literature, but also in chemotherapy and the hematologic malignancies, also in prostatic biopsies. So let me give you two examples.
So I'll just interject here because I think this is a very good point to debate.
Yeah.
We presented our data on this at the International Infectious Disease meeting, and our concordance was only 12%. So between the MDRO and the rectal swab versus the organism that we found, it was just 12% in our setting. So there is still I think a dichotomy there, and we still need more data on this particular point.
Your point is really well taken because it can vary according to the settings. The point which I would like to make is that with sequencing, so the ideal way to do, we planned it, we couldn't do it. The multi-locus sequencing, MLST, that should be done from the colonized bug and the infective organism to
Yes.
find out the genetic linkage between these two and to demonstrate whether they are the same organism. So this strategy, surviving sepsis guidelines have already recommended in their propositions for starting empiric antimicrobials that you look at previous 3 months, what was the infective organism, what was the bacteria colonized in their rectum, and the risk factors for MDR. So it is nothing beyond, the recommendations, but there is a equipoise that if you don't treat with colonization if you don't treat with the knowledge of colonized bacteria, then there could be a potential harm. So this pragmatic randomized trial, this is a concept and proof of concept. It's nothing beyond. We need to go to a step of confirmation.
Yeah, I agree with you
obviously.
completely. Thank you. Point very well taken, Ambun. A big round of applause because it's a very difficult study to do. So I think it's very easy for us to sit here and criticize, but I think, no, it's a very, very difficult study to do. So Nipun, you have done a fantastic job. Well done. And I'd like to thank all the panelists, speakers, Matthias, and the chairpersons for this lovely session. Thank you.
I request all of you for a picture, a group picture.